This is Namitha Saitnotha for NEJM Catalyst. Today, I'm speaking with Steve Meth, the Chief Patient Experience Officer at Johns Hopkins Medicine, about an important question that I know is top of mind for me, given my clinical work as a hospitalist, and that is, how can we better support family caregivers of acutely ill patients? During our discussion today, Steve and I will talk about the why, the what, and the how he and his colleagues are addressing this important and growing issue. Steve, thank you for speaking with us today.
Namitha, it's my pleasure. Thanks for having me.
Let's start with setting some context. Tell us a little bit about your role at Hopkins and why and how supporting family caregivers, or care partners as you call them, has become a priority amongst all the other priorities that I know that you and the system already have.
It's an incredible role. I've been here for less than 2 years in an organization that attracts talent from around the world and collegiality that's just intoxicating. And you'll see that permeate as we discuss this body of work. My responsibilities are on the reactive, as traditional patient and family complaints come in through any health system, and on the proactive side, understanding, identifying, and removing points of friction for our patients, for our family members, and for staff and providers. And so this is when we think about family members or care partners, the most common iteration, it's a really core constituent of our customer or client base, but I think they receive less than their fair share of prioritization in sort of traditional patient experience design work. And like the very simple answer is they've been excluded. Your care partners, family members excluded formally from completing HCAP, so the formal patient experience survey instrument. They're not the customer in the bed, even though they may be providing the payment source for our customer and guiding their decisions. And it's just an opportunity here that I couldn't wait, Namitha, for years future to start designing the work specifically around improving reliable care, emotional care for the care partners. So that's the shorter version. But that should kick us off for now, and look forward to diving in deeper.
I appreciate you naming care partners as a key stakeholder, as well as basically a key member of the care team. Tell us a little bit about the specific problems that you are trying to solve and what some early ideas are about how to do that.
Specifically, in critical care spaces, there's just too many decisions that are so preference sensitive. And all of the high-tech tests and the results require such context around like detailed patient history. And too often the therapeutic choices that the patients or the care partners have to make really about how invasive to be or when to stop. These need to be guided by a nuanced understanding of our individual patient values. And these patients, they're just too sick, to provide them themselves. And, this is before even contemplating often how sleep deprived, how anxious, how exhausted, care partners often are in this role, that they may face. Let's knock on wood and be hopeful, but care partners may be in these situations where they're in an ICU having to make these decisions only once or twice in a lifetime. And it's, colleagues at the University of Maryland and others from across the country have studied this, and more than half of care partners experience some form of burnout themselves. And they're just truly unable to participate emotionally and cognitively oftentimes because they've got some of these basic needs completely unmet. And, more thoughtful folks in this space describe this than myself, describe this as care partners experiencing learned helplessness, where they're along for the ride, but they're a zombie and not a true care partner in the manner that they want to be and that we need them to be. So all of these things overlap for me, not just in personal lived experiences in the past as a care partner, but this year, just trying to understand more of the burnout and overwork for the critical care clinicians who are just so skilled at saving lives in the ICU, but they may have no expertise in helping care partners find a place to sleep, figure out how to provide discounted or free parking or childcare or all these basic necessities. And even worse, what they described to me early in scoping this work is that sometimes they can be providing care by default, or they describe to me clinical inertia, where these critical care clinicians fear they're providing care that the patient may not actually want. And this they describe to me as a tremendous sense of burnout. And so this fostered really rich conversations that we'll talk about more, to say how do we address burnout on the critical care clinician side? How do we address burnout and this learned helplessness from our care partners? And think about designing a system that's more reliable than the individual expertise many folks have fostered across probably all health systems across the US to address some of these needs, but we're not hitting them for the high percentage of reliability that we strive for in other arenas. Does that start to make sense, Namitha, with your lived experience, your professional experience, and what you're passionate about? Are some of these resonating with you?
Absolutely. Absolutely. And it is here where I need to make a disclaimer that I apologize I didn't make earlier in the conversation, is that when you talk about eliciting and honoring patients' goals, values, and priorities to inform their care, that is a passion that stems from my work at Ariadne Labs on the Serious Illness Care Program. And the second disclaimer is when we're talking about the burnout and the challenges that family caregivers and care partners are suffering from, then I need to share that I also work with IoniCare, which is a startup company focused on supporting explicitly family caregivers with the understanding that caregivers need support and empowerment, and in turn that then helps patients and improve care outcomes. And I, from a firsthand frontline clinician experience, can speak very much to the moral distress and the symptoms of just emotional exhaustion that are a key component of burnout that happen when you feel the challenges, but also the privileges of helping an individual patient navigate their goals and their plan of care, and what it feels like to have a care partner by the bedside who is able to support and help that conversation, and also what it feels like to not have that by the bedside. And with that context, I'm very interested in hearing more about some specifics. What are some of the ideas? We're aligned at the 100,000-foot view, and I respect that you're early in your journey, but tell us a little bit about what you're thinking about at Hopkins.
I've never been more excited to hear a disclosure too. Our professional interests are so aligned here. So, and I need to give credit to a colleague at Hopkins, Jack Iwashna, a critical care doc, who was really instrumental in informing where we are now, which is a core set of constructs, ideas, and positioning to create a flagship to demonstrate efficacy. So let's get a bit more specific. And let me just say that right now, this is a great time to have this conversation. There is no final product. There is no one way to do this. I've experienced care partner caregiver centers in excellent health systems across the country, and I think we all have a lot to learn from one another. And a great output from this conversation would be connecting with colleagues that are investing in the space and want to create really a new standard of care embedded into critical care practice for care partners. Let's be more specific. Okay, so we gathered critical care frontline teams, patients, care partners with lived experience in two of our hospitals in the Johns Hopkins Health System in this past year. And we heard story after story of clinician time and not devalued or undervalued, but just time spent making sure that the logistical and emotional needs of care partners are met. And then I also heard them over and over again said we spent a lot of time waiting for families to gather and then for families to get to that decision point needed to escalate care or to reduce care. And that really felt like a lot of non-value added waste. And where we're at capacity, and I think so many others are, this is something we're really hoping to address and to dive into for an ROI to make this sustainable. And then just listening to our care partners, not in the critical course of their illness, but maybe a few months, a few years later, as we approached them and did a gap analysis here. They said in these very moments where they were sitting by their loved one's bedside, they can't afford to waste their emotional, their intellectual reserve running, to feed the parking meter or to wait in a line for 15 minutes to get food. And so we walked away with 4 concrete themes where we found more alignment than disagreement, which I loved. This is really about finding coalitions and themes amongst needs. So the first one is a shared understanding there needs to be a physical space for respite with amenities, sort of a business center light for care partners be able to hop on a quick meeting if they need to fear not losing their employment, to be able to grab snacks just quickly at all hours. And perhaps so critically in this one, just a space to rest, to close their eyes, to be physically close to their loved one in the unit, but not too far away. And I heard that over and over again, so that they can be prepared, they can make the good decisions, they can be the care partner, the son, the daughter, the spouse that they want to be in these critical moments. Second, what we learned was we need to be more reliable in facilitating access to our internal resources. What we found is, case management, social work, specific provider or nurse may be more expert and fluent in referring for spiritual care, referring or getting, a simple care kit that has earplugs, toothbrush, eye shades, connecting care partners with, pet therapy or some form of, someone else to keep them company, perhaps a trained emotional peer-to-peer supporter, which really belongs in this third bucket oftentimes is external support resources. So stroke survivor groups, cancer care partner groups. This peer-to-peer lived experience is something that we cannot provide, and patients and care partners really want and seek. And so connecting the care partners sooner rather than later, letting them know that they're not alone and they could connect with others with lived experience seems to be a top reoccurring priority. And then external support resources, like how do we provide folks with subsidized nearby lodging, transportation to and from hospital, childcare support? These are really the 3 core themes, like physical respite with amenities, facilitating access to internal resources. Third, external support resources. But the fourth and maybe very important and critical is that we create infrastructure to help advance health literacy amongst our care partners, continue to promote informed decision making with the team, and really just use this center, this care partner center, to guide improvements for how we could help orient care partners and patients in our critical care spaces, and just get them feeling confident, comfortable, and effective in their advocacy. I get excited about our early learnings and seeing these coalitions of colleagues at Hopkins, colleagues in sister systems, and patients and care partners with lived experience coming together to say, we really need to do these 3-4 things. We need to do them more reliable, and they shouldn't just sit in Hopkins. We can and we should create a structure that's really sustainable, that's cost effective for any small or mid-sized hospital to launch and sustain in their facility.
I very much agree with your commitment to generalizability, because a lot of our listeners may say, well, that's Hopkins. They have the resources and the money to invest in something like this. And what I'm hearing you say is, let's come up with approaches that are generalizable across all different types of healthcare systems. The second thing I'm hearing you say that is also important is this notion of consistent and reliable excellence. I know, at least in my hospital here at the Brigham, we do all the things in your 3 buckets, but we do them inconsistently sometimes. It's not necessarily every patient every time. And I also know that there is a desire to do it every patient every time. And my hope and expectation is that what you all are building at Hopkins will become a blueprint so that these activities that are so critical will become more consolidated, more consistent. I know in some early planning conversations, you and I talked about reclarifying job descriptions and or tasks so that there is more transparency and, again, consistency amongst who does what. And that alone, I think, will have some of the sustainable, generalizable impact that you refer to. Let me ask one last question. I understand the impetus to start in the ICU with critically ill patients and their care partners. Let's assume that effort will be a resounding success in the chapter ahead. From your perspective, what would be next on the horizon in terms of supporting care partners and their loved ones?
I love this, and I think I want to say there's no pride here that this is a Hopkins pursuit. This is a shared passion, and that is so much of the fun of this. I think, let's get this right. I think we can create a role like a care partner center coordinator. Think LCSW, clinical psychologist, or even like a psychiatric occupational therapist, which is a neat role. And just think of to get a little bit more granular, their role would be to review the critical care census, right? That's our starting point. Communicate with the charge nurse daily, make initial outreach to care partners, educate on the critical care processes, and offer support every 24 hours. And, like you asked, where do we go from here? I think we need to get our prioritization right. So our thinking at onset is to prioritize care partners that are experiencing learned helplessness, where just a little bit of activation can pivot that care partner to becoming actively and meaningfully able to participate in care. And then think like second priority would be care partners where there's friction. It's already grading. They're already grading on the care team. And it's really important to promote well-being and that sense of safety and retention amongst the team. So I think, we start critical care, we demonstrate outcomes, think retention, think employee engagement, think recruitment for a critical care team. Who wouldn't want to have someone creating, this environment where it's every care partner every time gets this emotional and logistical support that they need? And think market share. If we can distinguish, at onset at least, my hope is this will, a little bit of competition can spur, more investment in this space. And then for ROI and getting a little bit of buy-in, my hope is that a single FTE to start this work can justify improvements in engagement, retention, and with changes to HCAHPS coming in January of 2025, where we're able to ask care partners to complete the survey, and we're asking about family engagement and preparation for discharge. I think this contributes to even more of a compelling business case. If length of stay weren't enough and weren't front and center for everyone else, I think this can only help. So, Namitha, that was a long-winded way of saying, I think we need to show the evidence that we can get this right in the critical care space. And my hope is we can prioritize and triage without creating an onus on the front line to overly survey care partners, and to increase the reliability, get these support services to every care partner every time. So let's build this coalition. And my thinking here is we have to create a price point where it's accessible. $200,000 is my goal. $200,000 of cost, per health system per year to get a model up and running. All in, I think most health systems can afford this. And even if it's started with a little bit of grant or donor funding, my hope is it will prove itself in spades and become sustainable. And Amitha, get to that point where we could invest additional resources to serve more folks, and to think how the support can continue through transition to home and beyond. Also, we just know how vulnerable that time and those spaces are as patients transition home.
I really appreciate A, your optimism, and B, your big, bold thinking, because that is what we are about here at NEJM Catalyst. Thank you so much for joining us today, Steve.
It's been my pleasure. Thank you, and look forward to the conversation continuing.